academies of sciences, engineering, and medicine. And some people may be familiar with these consensus reports that they do, and some people may not. So I'm going to do a little bit of background on it. When we think about evidence-based treatments, these are developed both through research and also through things like meta-analyses or systematic reviews, as well as things like consensus reports. So this is a consensus report specifically on using medication to treat opioid use disorder. And a consensus report is typically written by a panel of experts and a professional writer. And so I was actually on this committee. We met in DC, and it was experts from all over the country, which was a very interesting experience. And it drew together people from a variety of different perspectives. So there was someone there from School of Public Health. She was an epidemiologist, so that was her perspective. There was people who do bench science in the area of addiction, specifically opioid use disorder. There were clinical providers, so I was certainly representing social work, and then there were MDs, and then there were researchers who also had some clinical background, as well as people who were straight research. And so it was a variety of different people, again, from all over the country, who came together to try and make sense of what does the evidence say about what works for the treatment of opioid use disorder with regard to medication. We were presented to by, I think there were 2.5 days of expert panels that presented to us, again, from experts all over the country. And this was a consensus report that was sponsored by NIDA and SAMHSA collaboratively. And so they wanted the basic question, actually, should we scroll through? It was called Committee on Medication Assisted Treatment for Opioid Use Disorder, and then the sponsors were SAMHSA and NIDA. And the charge to the committee was to review the current knowledge gaps on the effectiveness of medications, examine how medications can be effectively delivered and in what settings and what populations, to identify challenges in terms of implementation and uptake, and identify additional research needed. And so this information was gathered both, as I said, from kind of expert panelists, as well as what it says in the current literature with regard to research. And those are the committee members. So the report kind of goes through some background and then generated 7 conclusions. And so we can talk about what people think about these conclusions, but it gives us a sense of where the field is headed. There were some very heated discussions among people on the committee. One of the discussions that I was involved in that was most heated from my perspective was the use of behavioral interventions and how much do they help and should they be required. We know that in West Virginia, the way that the MAT rules stand now, behavioral interventions are required, but this consensus report, as you'll see, actually does not think that that's a good idea. And so one of the things that consensus reports can do is inform policymakers to perhaps make changes to make medications more accessible to people who don't necessarily have the ability to connect with behavioral interventions, or may not even want to have behavioral interventions. That being said, it doesn't mean that behavioral interventions are effective. It's just that behavioral intervention shouldn't be a barrier. So that was kind of one example of some heated discussion that occurred around that, because obviously my background is in delivery of behavioral interventions. And so there's a professional investment in wanting to see that represented as a form of treatment that should be included in the treatment of opioid use disorder. But I'll kind of run through the background here. Some of these statistics you guys are probably very familiar with, and others maybe not. So in general, the opioid crisis in the US has affected over 2 million people with opioid use disorder. And as we know, over 47,000 people died from opioid overdoses in 2017 alone. This is tied to the emerging public health crisis of infectious disease. So we know the increase in opioid use disorders has gone along with an increase in IV drug use, and then related to increases in hepatitis C, endocarditis, and HIV. And then the socioeconomic consequences include healthcare costs, loss of productivity, criminal involvement, housing insecurity, and I would add to that impact on families as a whole and the Child Protective Services system that we've certainly seen in West Virginia as more and more kids are needing access to foster care, and CPS has been involved in many, many more families where there's opioid use disorder and substance use disorder in general. So you guys all know this in terms of the definition of the diagnosis of opioid use disorder and what that means. So there's compulsion and obsession. There's repeated use, which results in neural structural change and function. So there's brain change. And then there's behavior and social changes. And medications are really intended to normalize brain function and structure so that, as Dr. Sullivan used to say, so that people can go about the business of recovery. Because when people are struggling with being able to get out of bed, they can't really engage in an active recovery program. So medications often allow people to feel well enough to engage in active recovery. And the medications that are approved to treat opioid use disorder are methadone, buprenorphine, and extended release naltrexone. So these are the FDA-approved medications for OUD. Methadone and buprenorphine have a lot of evidence behind them and are linked with better long-term outcomes and improved social functioning. All three medications absolutely have been proven to reduce opioid use and cravings. There's less research on the long-acting extended release naltrexone. There have been some studies. One of the most difficult things with the long-acting naltrexone is initiation onto the medication, because people have to be medically detoxed off of opioids, and that creates one of the biggest challenges to getting people started on the medication. Either when the studies that have been done, often there's a lot of dropout in the beginning of those studies because people can't kind of get over the hump of getting through the withdrawal. And these are some interesting statistics that everybody may not be aware of. So only 20% of people with opioid use disorder receive treatment. So that's really low. And then opioid use disorder is actually the leading cause of death for those recently released from incarceration. And people may know that that's as a result of when people are incarcerated for a period of time, their tolerance for opioids goes down. And then they get released from prison and they try and use the same amount that they used prior to going in, and they overdose because their tolerance is lower. 5% of people in prison with opioid use disorder receive medication treatment. So that's one of the things that the committee was very profound. It was very clear that the prison system is not interested in embracing the most effective medications to treat opioid disorder, which are methadone and buprenorphine, because they are seen as substance of misuse and they don't want them in the prison systems. And yet they're an effective treatment for this disorder. And so one of the consensus opinions was that we need to make this more available to people who are incarcerated, and also immediately available when they get out of incarceration. There's a program in Rhode Island where when folks when folks get out of prison that day, they get connected to medication-assisted treatment. They have a program that's affiliated with the prison system that gets people in right away, same day, which is awesome because it really reduces the risk of overdose. And then 6% of substance use disorder facilities offer all three medications. Certainly, there are all kinds of regulations around prescribing methadone, even more so than buprenorphine. But as we know, you need a X waiver to prescribe buprenorphine. So both of those are barriers to access for patients. and are frankly barriers to prescribing for providers. And so very few settings in which all three medications that are FDA approved are available. Other barriers to access include high levels of misunderstanding and stigma among public and professionals. So if you actually go and read the report, I think you provided the link. So we do provide the link to the whole report. There's a summary, which is much shorter than the whole report. The whole report's really long, but it talks about that some of the research that's been done among professionals and the stigma around professionals actually either prescribing, being willing to prescribe, being willing to get waivered, or even being willing to recommend to patients to seek medication-assisted treatment is quite low. We've also seen among our own patients, I'm sure, the stigma that family members have. So you're just trading one drug for another. Why would you do that? You need to get off that medication. And patients often, if they're depending on family members for rides or for money to help pay for the prescription, that can be a real barrier to them accessing care. We've seen an inadequate professional education. So oftentimes providers don't really understand medication-assisted treatment. They don't understand the disease of addiction. They don't understand that treatment works and people get better, because that's not necessarily what they see, especially in acute care settings. Often providers only see people who are in active addiction and are not doing well. They don't see people who have done very well in recovery, because those folks aren't showing up to their service. Regulations around methadone and buprenorphine are certainly barriers. We know that from our experience in our own state with regard to the way that methadone clinics and buprenorphine prescribing is regulated. And Dr. Berry is working to change some of that, I know, at the state level. We also have a fragmented system of care, and current financing and payment policies can be barriers. So, for example, Medicaid does not yet, as we heard on the call 2 weeks ago, Medicaid doesn't pay for Vivitrol, and so that becomes a barrier to treatment and that particular form of treatment for many patients who are on Medicaid. So these are the 7 conclusions, and people can ask questions as I go along. I think I like interaction if people are interested in interacting. But I'll kind of just read through them, and if people have questions, we can talk with them. I think the first one is fairly basic. There wasn't a lot of, on our committee, there was not a lot of discussion about this other than reviewing the evidence that we know supports this statement, which is opioid use disorder is a treatable chronic brain disease. I think the MRI research that has been done by Neurovolca and others has certainly proven the evidence basis of opioid use disorder and substance use disorders in general as a chronic brain disease. You can see the changes in people's brains on a structural level, on a neurochemical level, and on the level at which places in the brain communicate with one another. So that can all be tracked on fMRI scans. Any thoughts about addiction as a brain disease? No, great, okay. Conclusion 2, FDA-approved medications to treat opioid use disorder are effective and save lives. So the literature is very clear about these medications reducing overdose risk and helping people stay in treatment. And those are obviously 2 outcomes I think we are all interested in. And which is, to me, what makes it so surprising that they're underutilized, because the evidence that shows that they're effective is robust. And so that gets us back to the stigma, which is really one of the major barriers. Long-term retention on medication for opioid use disorders is associated with improved outcomes. However, as you guys who are starting up programs or currently have programs know, the retention rate is not good. it's about 50% at the 3-month time frame. So someone who enters into treatment, if you look at them 3 months later, only 50% of people are retained in treatment. And so one of the things that here we're certainly working hard to try and change and trying to come up with ideas of just how to better retain people in treatment. We've been talking about, or we have talked on the call sometimes about recovery coaches as a resource for doing that. We have adapted the COPE model to try and increase retention, especially for special populations such as pregnant women. But we certainly are open if people have experiences where they're improving their retention. That's a great discussion for this call, because retention rates are not very good, given that we know that this is an effective treatment.
You guys have any thoughts or anything? If you do, just make sure you unmute yourself. You're all muted.
And then the fourth conclusion was the lack of availability of behavioral interventions is not sufficient justification to withhold medications. So as the West Virginia regulation currently reads, West Virginia is not following this recommendation or conclusion. And so perhaps we can, in this state, work to change that, because it then becomes a barrier for people to access treatment because they either cannot or are not interested in receiving behavioral interventions. What I did not realize until we were reviewing the evidence in depth is that there has not been a lot of research on behavioral interventions. And some of the research, the big randomized randomized controlled trials that have been done, do not all conclude that behavioral interventions increase success in patients or have improved outcomes. Well, when you dig down in that, some of it has to do a little bit with study design. So Jim and I participated in a study about 10 years ago that looked at exactly this. So some patients were randomized to medication management only, and other patients were randomized to medication management plus behavioral intervention. And there was really no difference in the outcomes for those randomized to medication management only versus behavioral intervention. When you look at the study design, one of the things that came up was that the patient would meet with a physician for a half hour, and the frequency adjusted over time, but it was initially weekly. Now that is not standard of care. So it's very rare that a patient would meet individually with a physician to be prescribed medications for opioid use disorder weekly. So what one of the conclusions could be is that that was actually a behavioral intervention, that the psychiatrist or the provider talked about behavioral things and changes that the patient could make in those med management visits. And so it wasn't just a med check, so to speak. And so some of the studies did show that behavioral interventions, especially with patients with comorbid psychiatric disorders and complicated cases with a lot of psychosocial patients with a lot of psychosocial problems, those studies typically show that behavioral interventions are effective. But in general, the evidence is not entirely clear. That being said, there are not a lot of studies out there, because typically what gets funded is medication trials, not behavioral intervention trials.
You know, the Cochrane reviews have kind of shifted on that. Their earlier studies suggested, as you found, that there was not a measurable benefit from requiring psychosocial counseling. And I was looking around for that article, and I found some much more recent ones that are coming around the other direction. And it might be a matter of good psychosocial counseling is useful, and maybe not so good psychosocial counseling is not as useful. And of course, requiring it when it's not available, that's no good anyway. But the more recent studies are suggesting perhaps more and more that the psychosocial counseling is important. I wonder if you have a person who's doing well on maintenance for many months or many years, surely the psychosocial counseling should be less required. And I'm not sure West Virginia is flexible enough on that.
Right. And you're right. So the psychosocial counseling is highly variable. So the behavioral interventions that have been shown to be evidence-based are contingency management and CBT and motivational interviewing. So those are the main ones. But oftentimes that's not what's necessarily being utilized. So we know at methadone clinics, they require counseling, but it's, for example, it's unclear what kind of counseling that is that people are getting. So it's hard to test whether it's effective or not because it's not clearly defined what it is. So that's a great point. Thanks, John. Conclusion 5 is that most people who could benefit from medication-based treatment for opioid use disorder do not receive it, and access is inequitable across subgroups of populations. So we had a discussion about a variety of different subgroups, including adolescents, pregnant women, elderly, and LGBT folks, as well as different kind of racial and ethnic groups. And it's when you look at those studies, it's interesting. It's really, really inequitable. There's a lot of controversy about the treatment of adolescents. There's not a lot of research on how to treat adolescents with opioid use disorder. And there's much more research among minorities on methadone, because typically methadone is located in more urban settings, and so the utilization is higher among minorities in those kinds of settings. And so there's not that much evidence about if buprenorphine is as effective in different populations, or methadone is as effective in different populations, just because it's skewed based on where people are living. And trying to think of those. Oh, and then for pregnant women, methadone is still considered the gold standard, although when we look at the data on neonatal abstinence syndrome, clearly the rates of, or the severity of neonatal abstinence syndrome is lower among pregnant women who have been on buprenorphine during their pregnancy versus methadone. And that has been studied pretty clearly. The Mother study in 2010 by Andre Jones was kind of the landmark study that established that.
They talk about the geriatric population at all?
So simply that it has not been studied, and that the geriatric population does not access medication-assisted treatment and often go undiagnosed. So the geriatric population often is prescribed many medications. Their compliance is not great with medications. And they're more complicated to figure out what may be going on with in terms of medication interactions as a result, and that they underutilize opioid use treatment, medication-assisted treatment for opioid use disorder. And conclusion 6, withholding or failing to have available all classes of FDA-approved medication for the treatment of OUD in any care or criminal justice setting is denying appropriate medical treatment. So the conclusions are getting really strong. We were getting excited here because the rates of death, when you look at the rates of death among individuals coming out of the criminal justice system and prison specifically, are just astronomical. And so it really feels unethical is what it felt like to us. And so withholding these medications should be considered unethical. I think we originally had the unethical word in there, and then we had to take it out because it was too strong. But the take home is that we need to increase the utilization of FDA-approved medications. And then the final one was confronting the major barriers to use of medications to treat OUD is critical. And again, stigma is one of those major barriers, as is all of the regulation, whether it be regulation at the level of reimbursement or regulation at the level of, like in our own state, how you need to run a clinic or run a service that's providing OUD. We've already seen, even in the last couple of years, we've seen much more innovative ways to do this. So we now have PAs and nurse practitioners that are now able to get an X waiver. So that is huge, I think, in terms of increasing access and also increasing the diversity of who can prescribe, which then filters down into educational settings. So that my hope is that PA programs and nursing programs, and as well as medical programs, will all have training on prescribing medication for substance use disorder, as well as general training on addiction and treatment. So some of the knowledge gaps, it was interesting to see were a lot of knowledge gaps. There are very few long-term comparisons of the FDA-approved medications, as in none, that go long-term, and that's one of the problems with the randomized clinical trials, is they only run for so long, and so you don't have long-term comparisons. The studies on behavioral interventions do not indicate which kinds of interventions benefit which patients, other than, as I said, there is evidence to show that patients who have comorbid psychiatric disorders absolutely benefit from behavioral interventions in addition to medication. The studies of the potential need for specific treatment guidelines for subpopulations, there are really none of those. There was not even any consensus among all the experts that we spoke with about, say, how to treat adolescents. And the committee was not actually supposed to come up with recommendations. That's why we call them conclusions. But there was no consensus about, if an adolescent presents with OUD, how do you know if they're a good candidate for medication-assisted treatment? Does it depend on the severity of their diagnosis, mild, moderate, or severe? Does it depend on how long they've been engaged in substance use behaviors? So there was really no consensus because there's been no study. The development of new medications and approaches and formulations is absolutely needed, and that is underway. Historically, the funding for substance use disorder research has not been robust. I think that is changing now that we are really seeing people embracing the idea that this is a medical disorder deserving of treatment, and that it is a brain disease. So hopefully more funding will be available. And then the research on how to drive real systemic change to increase access and use of medications for OUD is needed. And I would add to that retention in treatment. How do we increase retention in treatment so that more people can not only access treatment, but want to stay in treatment? Just the key messages: opioid use disorder is a treatable chronic brain disease and should be treated accordingly. Medications are effective and save lives, and the medications are not available to many people who need them. That's actually, that last message is why we do what we do, as in why are we all here on ECHO, and why are we involved in things like the STR expansion of MAT, is to try and increase that access, to try and train more people in prescribing and in delivering service around medication-assisted treatment. And so I actually felt really good presenting this, because I feel like our group here, the group that's involved in ECHO, is absolutely involved in trying to improve access and training. I think that's the last one.
I think if Dean is trying to.
You guys can hear me okay?
Yes.
Now we can. You're on mute.
Okay, sorry. So when I think about retention, we approach opioid treatment as a chronic disease, yeah? But a lot of people in our programs, they're not retained, not because they're not compliant with Suboxone or buprenorphine, but rather they're using meth. And if you think about something like metabolic syndrome, right, where you have diabetes and hypertension and obesity, I wouldn't treat someone's hypertension with metformin and say, oh, you're doing well, for your diabetes, but you're not so good for your hypertension. And I'm giving you this metformin to help the hypertension when metformin doesn't help hypertension, right? So what do you all think we should do for that? Because methamphetamine is not treated by buprenorphine. I know some studies show, well, it reduces craving, and there's some people use less, but those studies are not conclusive. And we know people are on buprenorphine to help them work their recovery, but buprenorphine is awesome for opioids and nothing else. So when we have people in programs and we're having laws or guidelines about that program based on something that is not treated by the program, to me, it definitely affects retention. That's a flaw in our program. I mean, what do you all think, though?
Yeah, I guess that's why I constantly am trying to send out the message that we do not. So looking at this disease, I'm even kind of nervous. I'm getting a little bit more nervous than I have in the past as far as calling it a brain disease, because I think that's too reductionist.
Yeah.
And that it's more than a brain disease. It's a whole person disease, and it's biologic, psychologic, and social. And so for the opioid use disorders, we have a very effective medicine in buprenorphine to deal with the biologic. And in many ways, that's the hook to get these people into all of this psycho and social services that help with the addiction. And so I see our program, the COPE program anyway, as unique in the sense that we're looking at the medicine as just one aspect of the whole comprehensive care. And that when somebody's coming in with opioid use disorder and methamphetamine, is we are able to help them biologically with their opioid use disorder with buprenorphine, but we're also able to help them with the methamphetamine if they stay engaged in the psychological and social therapies that we're giving. So that's the key, right? Is that we're giving them regular doses of the psychosocial therapies for their addiction, even though we don't have a medicine to help with their methamphetamine. So that's the way I conceptualize it.
Yeah.
And this consensus report was very narrowly focused on medication. And so I struggled a little bit, obviously, because I am not a prescriber. And so I wanted to talk about other stuff, but people were like, no, we're only talking about medication. But there is a sense that, especially for people who have the more severe their opioid use disorder, or the more severe their substance use disorder, they're going to have all kinds of symptoms that affect more than biology, as Dr. Barrett was saying, that affect their social situation, their financial situation, their legal situation, and that medication does not help with that. Other than to help them stay hooked into services that can help them with that.
Right.
Another thing to think about with people who are using upper and downer pairings with substance use is that it's not really a self-medication kind of model anymore. They're not just treating agitation or aggressive behavior with something that's a downer. They're also taking an upper, so it's more complicated. It's a complex addiction. And that's why I think behavioral interventions are so important. In the real world, you see complex cases more than you see just an opiate use disorder by itself.
Have you all had success with contingency management?
So I always say that the way that we have our groups set up is kind of like contingency management, because the med management group occurs first, but they don't get their prescription until after they go to group therapy. So some people say that's coercive. I see that as contingency management. You get your medication after you go to group, because we think that group's actually really important. And we don't have a contingency management program here in terms of paying people for urines or paying people for sobriety. Some of our therapists have gotten really creative in group with just small tokens, small rewards during the course of treatment to celebrate I mean, we talk about celebrating successes, but it's really about rewarding certain behaviors, like consecutive days of sobriety, or getting your kids back, or whatever measures, kind of outcome measures we see as successes. And so we don't have it across the board in any kind of comprehensive way, but different therapists have worked in some contingency management strategies into their groups.
I had an idea for rewarding the whole team of people in the group. So if everybody was abstinent, then the whole group would get a reward, and kind of using the team effect as well as the contingency management approach.
Yeah, like Laura, I always saw kind of what we did as a contingency management that was built into the actual, model that we use here anyway, and that many of you all do, where you are rewarded by less frequent visits, as you have a number of days of sobriety, et cetera, et cetera, et cetera. But I think it would be worthwhile thinking through, especially with the increasing stimulant problem, methamphetamine and cocaine, which has demonstrated specific contingency management benefits, are there things that we can think about, all you can think about, to try to build into your programs some form of contingency management with stimulants? Get creative. Try things. It can't get worse than what we're doing right now with these. Yeah, I mean, it can't get any worse. So get creative and start thinking about ways to do that, and let's see what works. And one of you out there might have a brilliant idea that you start trying this and testing this, and then you could share with the rest of us, and then we could start making this a national model.
Especially for folks who have smaller programs, because it's much more manageable to do on a smaller scale, and test and see what's really useful and what patients like, because you can get feedback really easily from them.
One interesting thing about so many of the studies is, as you suggested earlier in the talk, that you're looking at urban centers and seeing how methadone works, and then you're trying to compare that to people using buprenorphine in that same city, in that same area, maybe in that same demographic. And I often think of the people living on the mountainside. There are a whole lot of them around here. No cars, no driver's licenses, no transportation. They're not studied at all. They don't exist. They're not there. And the whole big style MAT approach, like the COAT program, it's simply, I'm not sure it really is particularly applicable to people who can't get there, can't get to the center. And none of what we discuss in this excellent ECHO discussion here deals with the people living on the mountainside. That's all.
Yeah, and that's absolutely true. The primary reason that we lose folks in our program here is because they cannot get to treatment. The transportation doesn't work, their car breaks down, they get in a fight with the person who's giving them a ride, they don't have money to pay the person, logistic care doesn't pick them up. That is the primary reason that people drop out of treatment, is lack of transportation.
Yep.
This is Bill in Charleston. I think it's also a preventive kind of thing with them being able to get to 12-step meetings that can be reinforcing. I hear a lot of the folks who are addicted to meth, it seems like boredom is one of their primary issues, and that's not something, you can medicate the withdrawal from opioids, but you can't stimulate them to help with the boredom that they face. And some of them, especially like as you were talking about, who live in the mountain areas or the hollows, and there is very little stimulation otherwise. The transportation, in fact, I had one couple who was we finally suggested, why don't you move? Well, they wouldn't move because they couldn't leave their dogs. That was the holdup. I mean, that's their reinforcement. That's their support system. So it is very difficult to figure out contingencies for those kinds of folks.
Mhm.
What I tell patients who struggle with boredom is that entertainment isn't the answer to boredom. I look at goals as the antidote to boredom. And so if they can think about how they can improve their well-being and think of some goals, that makes life more interesting.
And I talk with people about purpose, right? And so, and that's related to goals. You know, how do you find your purpose? I worked with a young lady last week who she does great until her kids go and visit the grandparents, and then she relapses every time the kids go and visit the grandparents. And we basically had a group discussing, you know, what do you enjoy doing that has nothing to do with your children, or has nothing to do with your role as a mother? And they really struggled with identifying anything that they enjoyed outside of kind of the parenting role. And they had to kind of go back to childhood and remember, oh, this is what I did in like 8th grade that I enjoyed. I mean, these are younger women, but that was an exercise in and of itself. And it has to do with what makes me happy and what gives me a sense of purpose in my life. And medication doesn't do that.
All right, guys, are there any other questions or comments about this or anything? We have about 10 minutes.
Do any of the newer folks who have just recently gotten up and running want to let us know how it's going?
That was a good presentation. We always end up, we're all on the same team. We're all trying to do the same thing. There's a little bit of preaching to the choir going on. I sure wish I could get this message out to just people in the community. Medication is, I've had people in public meetings screaming at me that I'm murdering patients with methadone, screaming at me. And the audience is a bit stunned, but maybe there's 1 or 2 patients there on methadone who will stand up and defend me. But it's there's a very broad cultural antipathy to medication-assisted treatment, and if it's shifting very, very slowly.
You know, to encourage you, John, though, having been doing this for the last 15 years, I have seen quite a change over the last couple of years in the right direction. You're right, it's glacial change, slowly, but at least there's change in the right direction. I still get yelled at a lot too, if that makes you feel better.
It does.
Yeah, I had 2 kind of questions. First question was in regards to the frequent barrier of not having rides to support group meetings.
Yeah.
Is a group of local recovering addicts who started this little volunteer, it's not an organization, I don't think, but it's called Rides to Recovery.
Really?
Wow, cool.
Yeah, it's pretty awesome. It's on Facebook, and like if you need a ride to a recovery group meeting, they offer it 6 days a week. You just send the group a message.
Wow.
Recovering addicts that will go and pick you up. But my question was, like, they did an ad in the paper, and I didn't know, like, with this being kind of a volunteer type of basis and not really, you know, I'm sure they don't do background checks and probably don't have, you know, insurance coverage.
But at least for us.
But how appropriate would it be for us to promote that?
I think it's appropriate.
Yeah.
I do. Just the way I would promote any of the 12-step community-based groups.
Yeah.
You know, sometimes some we've been to, but most of them we're not going to on a regular basis, and we can't, right? We can't vet them necessarily, but you'll hear from the patients over time whether this is a good thing or a not so good thing. But I think you give them the information, they could do what they want with it. Just say, hey, I heard about this. This is a way to get to meetings. You might want to try it. Let us. So many times we're asking our patients, what have you learned from this? What are good meetings out there? Where are meetings that you can go and be open and honest about being on the medicine? And You know, you can ask them, try this out, tell us what you think. If this is a good thing, then we're going to, you know, make people even more aware of it.
Mm-hmm. It sounds really good. It's getting those in recovery, you know, they're giving back and giving. So it sounds really awesome.
Especially those that don't have driver's license.
Yeah, and multiple people do not have driver's license. So
I love hearing about the sort of the grassroots groundswell stuff that just raises up from people who have a heart for this and have a mission for this and themselves are in recovery and are trying to get back. That's where you see stuff really change.
We're seeing a good bit down in this area. It's really encouraging, I have to say.
Hey guys, where you're at, how's the stigma been in the community now that you're kind of up and running?
Not bad.
Too bad.
Yeah, I have to say it's not bad at all.
I wonder, Sarah, too, if that has a lot to do with the fact that you were willing to go out there early on and present yourself and go before the town hall and everything.
Yeah, probably. And the fact that we grew up in the area and everyone knows us, and you know, that probably definitely helps. One thing, too, just how desperate people are.
Yeah.
Desperation, you know, they're like, please help, anything. Something has got to be done. So.
And we've got 5 now. We're up to.
Well, I had the second thing I was wanting to talk about, if we can, is appropriate patients for MAT. Because we have patients that I really felt that they needed a higher level of care. Some they missed how many appointments?
A lot.
3 or 4 appointments, and had issues with rides, and there were a lot of red flags. There were a lot of red flags showing that they weren't really pursuing recovery, and maybe was wanting a little extra on their. I'm trying to say this nicely.
I feel like they were wanting to use the Suboxone in conjunction with their meth use. Seemed to be pretty meth heavy, and I feel like that was their goal, was just to have the Suboxone to supplement that.
You know, sometimes people come into the program with that being their goal, but once they start coming on a regular basis, then you kind of see those people weed themselves out, or they kind of get it, and then the culture of the group starts shifting for them, shaping them. But if they're not showing up and meeting, you know, the requirements of your program, then maybe it's not a good fit for them, and it comes down to what your comfort level is and what you're going to do with them.
And that's kind of where we, you know, went with them. They no-showed, and they did show for one that was not even scheduled. They just kind of showed up. Our docs went ahead, and calls to scene. Our docs went ahead and seen them, and I kind of set the guidelines down with them. And then the next day they no-showed and wanted to come later, and I was just, you know, I can do it now.
But
then
they got verbally aggressive.
Yes.
And I didn't know what would be the appropriate thing to do there, whether to just introduce them and let them come in and schedule their appointment again, just so that they're getting some motivational interviewing, they're getting some education, and getting that opportunity, or whether, you know, suggest a different level of care and give them other resources.
Yeah, well, it's always kind of trying to weigh that balance, because at the same time you don't want to cross the boundaries that you've set and the limitations that you've set for the particular treatment, and then it causes problems for all the other patients too.
We were looking at that also.
And you need to consider safety for the group and safety for the providers, right? So if people are feeling unsafe or feeling threatened, we would not typically keep someone in our program who is being aggressive, whether it be verbally or physically, to staff or other patients. And just to say to people, this is a place of safety. In order to keep everybody safe, we can't actually accept this kind of behavior. So if you're not able to to tone it down, we actually can't keep you in treatment.
That's how it was handled. Absolutely, that's how it was handled. Oh, thank you, guys.
Sure.
This is Dr. Morrison. I'd like to share something kind of related to that. I'm now telling people whenever they first come to my induction visits that about the only thing they can do that will get them thrown out permanently is like aggressive behavior, but that can include bullying, racism, homophobia. Because it's so bad for the group. And is that similar to what you're doing at WVU, or if you think that's too far to go to enforce political correctness on the group?
Well, I think, I mean, it would have to be beyond the political incorrectness, probably. So typically, if somebody's going in that direction and they're in treatment, I would speak with them one-on-one about how we would want them to change, the way they're talking or change what they're saying specifically, and why, because of the negative impact on the people around them. And if they're not able to change it over time, then that wouldn't be a good fit. But to me, because we are a group-based program, the safety of the group is really paramount. And so behaviors that threaten the safety of the group, in my opinion, should not be tolerated for very long at all.
I also got a lot of guys that like to sneak in 4-inch blades. If you caught one, would you throw them out permanently?
Well, I mean, in West Virginia, lots of people carry around 4-inch blades with no intention of hurting anyone. But we ask that people not bring those into our building. We actually have metal detectors now, but when we didn't have metal detectors, we would talk with people about not bringing, just leave it in the car. This is going to be a safe place for you. You don't actually need to bring it in. If you want to leave it in the car, that's cool, but we don't want it in the group.
And that we have medical detectors put in our general psychiatric facility years ago. I don't know, maybe 4 years ago now. And it seemed like everybody and their brother then was getting stopped with a 4-inch blade, because everybody carries a 4-inch blade.
Everybody and their grandmother.
And their grandmother. Apparently it's required in West Virginia to have a 4-inch blade. But people got used to it after a while and just realized you can't bring that in. So again, if nobody's threatening anybody with it, if they're threatening you with it or somebody else, and that's a whole different story. But otherwise, it's just part of your ground rules for the group. If you're going to come in a group, please don't bring a weapon of any kind.
And I wouldn't even call it weapon. I would say explicitly, any kind of knife, because some people wouldn't even consider it a weapon because it's just something they carry in their pocket all the time.
All right, awesome, guys. We are out of time. I wanted to make a couple quick announcements. I think you all got my email. Our next session is April 8th, and we are going to be reviewed by the Echo Institute to see how our program is run.
Everyone has to behave really well.
It's like
that means you, Dr. Morrison.
Yeah. So it's kind of a big deal. They do want to see our program specifically because we are not academic down, we are community up. The whole reason that all of these programs came about are because of the need in the community. And all of the other ECHO programs are not run that way. They are run with a dictated curriculum, not consulted by community members and the rural care providers. So it's very different from the way they actually do it out there. So we want to show them how effective and how good it's been. I think we're going to try to have, Camden on Gauley and New River Health, our two newest, are going to give the cases at that session. And then Tony Dicchiacchio is going to be giving a really great didactic about the new legislation that's been passed. So I just wanted to let everybody know, show up, look pretty, best foot forward, all that. All right. You guys all have a great day.
Thank you.
Thank you.
Thank you very much.